Welcome. My name is Gertie Boschma, and I'm a faculty here at the UBC School of Nursing. And I'm so pleased you all came. And I know you came for a very good reason, because I would love to introduce my colleague, Ranjit Dari, who is also here faculty at the School of Nursing. And we have worked closely on this project over the last year, and some of you in the audience have been part of the project, and Ranjit will explain all about it. Ranjit is a lecturer here in the School of Nursing. I try to think since when, but since a number of years now, hey?
Yeah, 2013 officially, but before that I was a clinical instructor, and on and off since a long time, on and off. Yeah.
And Ranjit also obtained her master's degree here at the School of Nursing, and that in some ways triggered our collaboration. And she will speak to that as well during her lecture. She is presenting a lecture in the series of historical presentations from the consortium that we now have here in the school for nursing history inquiry, we call it. And this project is part of those initiatives. So without further ado, this is the presentation by Ranjit Dari.
Well, good afternoon, and thank you for all of you for coming. It's a lunch hour, I know, for many of you, so it's like trying to squeeze it into the day. And thank you, Gertie, for that really warm introduction. So I'm going to be talking about public health nurses, and I am a passionate public health nurse. If anybody sort of describes me, they always describe me, I'm so passionate about my work and being a public health nurse. And I sometimes tease the students that I'm going to probably be taken out in a coffin from public health nurse because I love it so much and stay with it so much. So what the topic of this presentation is called Nobody Ever Asked Me About My Career, but it is looking at public health nurses in terms of their career and what we can learn about the history and their practice and how that practice has changed, and looking at the pilot project that we did in relation to that. So the goals of the session are going to give you a bit of context about public health nursing. Some people know what that is, but it is public health nursing is a very sort of invisible entity, and so a lot of people don't know that it even exists until they have a need it. And then I'm also going to be talking about the oral history project that Gertie mentioned and how that came to be, and the team collaboration and who we did collaborate with in order to get it. One of the big partners was the UBC Archives here in terms of setting it up. And then what are some of the themes coming from the participants' oral stories? And it's great to see some of the people that I'm going to be talking about that are in the room also, and what great the stories we have from them to learn from. So public health nursing, it is situated in community health, and so situated in community health centers in the different health authorities now currently. That wasn't always the case, as you'll find out as we go along. Currently then in Vancouver Coastal Health, there are 6 centers with public health nursing programs situated just in Vancouver. And then Richmond is considered community number 7, and then we have Coastal that also fits into Vancouver Coastal Health. I think one of the things people don't realize is that in fact UBC is also served by public health. So in fact Pacific Spirit Community Health Center, which is in Kerrisdale over on 43rd and Arbutus, actually comes and serves the population here for UBC in terms of UBC housing, where we provide the maternal newborn program, and then also in some of the licensed preschools and daycares that are on campus, because all licensed preschools and daycares have a public health nurse attached to it. And then also the school programs that we have a public health nurse with them. So we are out here serving our populations. In terms of what our work is about, our big focus is really in terms of promotion, so promoting and keeping our populations healthy through health education and building their capacity. And then another piece of our work, our big mandate, is around disease prevention. And so CDC, communicable disease, becomes our big focus in terms of looking at how we manage it when there's outbreaks, or currently now with the Syrian refugees. So who do you think has been their first contact in healthcare here in BC as they've landed. It's been the public health nurses. We currently have been running clinics for the Syrian refugees. On the first day, I heard that there were 300 refugees that came to the clinic that the public health nurses were running and were then met and health information histories taken. And then we, of course, then provide all sorts of clinical nursing services, youth clinic, child wellness clinics, and as I said, all the licensed sort of facilities has a public health nurse attached to it. So who is our client, as we refer to them? We don't call them patients, we call them as clients. Who is our client? Anybody and everybody is our client, right from individual all the way to large population groups. So the school is our client, a parent group is our client, our current neighborhood house where we are working is our client, and we then try and serve that population that comes there. So the settings can be a variety of places. So again, as I said, it could be homes, it can be neighborhood houses, it can be schools, it can be other community agencies, faith-based places, wherever the population is meeting, we try and then provide services to them. Some of you might have seen this. This is the new BC Guiding Framework for Public Health. It was released in around 2013 by the Ministry of Health, who then sets the mandate for public health nurses, in terms of their measurable outcomes that they're looking for, and so therefore guide the work. We also, of course, have the CR and ABC standards of care. We also have this community nursing health standards that guide our scope of practice. And then, of course, we are now currently then work for the health authorities and are based in the health authorities, but that's a big shift that you'll see as we go on. So what sparked this project? And Gergie mentioned a little bit. So I, after raising my kids, decided to come back and do my master's. It had always been there for me on the back burner. And so when I came and did my master's here at UBC, my thesis focused on public health nursing, but looking at the scope of practice in relation to health promotion. I love health promotion work, and so really had realized that there were some shifts happening and wanted to look at what strategies public health nurses were still engaged in relation to health promotion. And so one of the things I heard as I had interviewed for my thesis 15 public health nurses, one of the things that I continuously heard over and over again from the nurses was that our scope of practice is changing overall, and that we really don't have any history being preserved around it, and that we really need to look at to try to capture that history, especially as people are beginning to leave, retire, and there was that concern of the aging population retiring or the changes, and then also losing out because then we wouldn't know where they are, or that the memory loss beginning to happen. And so really that the push for trying to preserve that history. And then that we really wanted to get authentic oral stories of the changes that have taken over. And so looking at the past 5 decades, so the nurses that we interviewed for this project have been starting from the 70s and looking at what's been happening, because that's when the big changes happened in public health nursing, was over the last 5 decades. And so we wanted to capture that information so that we would have original stories, and then also begin to be having that content available for future reference, research, and education. I'm always amazed that the students think some of the programs have been there always, but no, they came because of some dynamic public health nurses who created some innovative programs. An example of that, again, in relation to Syrian refugees, is our Bridge Clinic. Bridge Clinic didn't always exist, but it was because of public health nurses who felt the need to provide that service that we have a Bridge Clinic, and we're easily now able to meet the needs of our new refugees. So we developed a team, and we came together. So I do want to give thanks to Dr. Boschma, who's the associate professor here, because then she was actually then, I would say, the one container holding us all together, and kind of really the encouraging supporter behind the scenes in turn, and then also the leader in terms of getting the project off the ground. And so we, myself, Gergie, Catherine Haney, who I want to again say thanks because she helped to set up today, and then Gilda Mahaber, my very long-time colleague and friend from Public Health Nurse. We came together, who was really, again, passionate about trying to retain the history of public health nurses. And so we came together to explore how could they do this, what was possible, what were the things we needed to consider, and what in terms of funding, or where could we go. And so we actually did a field trip to the archives, Vancouver Archives, to take a look at and see how that worked, what kind of information did they have, and how could we then collaborate with them in terms of future projects. So it was decided that there was quite a feasibility of us doing the project, and so we decided to do a pilot project. And so therefore the UBC consortium would provide the infrastructure and would be the home for some of our content in terms of organizationally running for us. And then also, of course, we needed that funding, so they provided some funding. And so that's when Erica Roberts joined us as a coordinator for the project. So she worked part-time for us on it. And the other person then that joined our team was Susan Walters, who couldn't make it today due to medical reasons. But she also then, between her and Gilda, became the key people that recruited and then went out and interviewed the participants. The other key piece that I want to talk about here is in terms of collaboration with the UBC archives. Because our content, our interviews were going to be sort of born in that sort of digital way. They were going to be audio tapes, but they were not going to be transcribed in any way, and therefore restored at UBC here in the library in that manner. And so really beginning to build collaboration, build partnership with them, and begin to understand the processes of how that could be done, especially around consent, legality-wise, who owned the material, who owned these audio tapes, if they were accessible to public, what did that mean? And so again, Gurji went and did a lot of the legwork around that in connecting with the library and working out the logistics of that. We did receive, then we did put in an application for ethics approval, and so received from UBC Behavioral Research Ethics Board approval to carry on with the project. So in summary, what were the goals of the project? Was to capture authentic original stories, so really looking at recently retired public health nurses who could then share their career stories, and so that we could learn how the scope of practice had been changing for public health nurses here locally in BC. And then beginning to really develop the competencies. Myself, Gilda, and Susan had never done any work around research in terms of oral stories, and so really beginning to build capacity of members in conducting oral history research, and then really beginning to look at how to capture that reasoning, and then understanding how that meant in the context of digital world. So this prompted us to have a training session, and we had a little mini education session done by Leslie McBain, who came and then taught us how to do, in terms of processes, oral interviews, consents in terms of audio taping. And so that was a great session that we as a whole team came together. And then it also helped to gel the team and build that collegial relationship amongst us all. So now from here on, I'm going to be moving out to what's coming through the stories of the public health nurses and sharing some of that. So really one of the things that came through was that there was a lot of changes in the political, social and environment and the context, and that had a lot of shift in who was employing public health nurses. So if you were working in the 70s and 80s, you worked for the city of Vancouver. So you were a municipality-wise employee working for the Vancouver Health Department. Our name tags would say Vancouver Health Department and would have a name. So you were here locally or part of the municipality. But again, that shifted in terms of looking at the influence of the change in the political environment, and so then especially around funding also, and so health boards were created. Initially, the intent of the health boards was to have that the community would tell health what they needed, what their needs were. And so those people that would sit on the health boards would be, yes, some of the managers, but it would also be people from the community coming to guide what were the needs of the community in relation to being in public health. And so we were then shifted over from the city to the health boards. And so it was Vancouver Health Board, Richmond Health Board, and then as the funding kind of shifted, that shifted to Vancouver Richmond Health Board. And then lastly in 2002, 2004, when the health authorities were well established, and again the ministry changed some of our mandate and also changed in terms of some of the budgets. We went under health authorities and became part of the acute sector under this one umbrella, and so Vancouver Coastal Health Authority, and so that's who became our employer. The ministry gives funds to Vancouver, to the health authorities. Health authority then looks after the public health community, the acute sector. And so then, as you can imagine, with each shift, our work kind of shifted in terms of some of the influences of the managers. And then also with the shifting, every time our logo would change, and the title would change, our business cards would change. So if you want to know where your taxpayers' money went, some of it was in those logos and business card changes. So as nurses, we were very frustrated at times because of the changes that was happening and what we felt was some wastage that we were seeing in relation to this. So what did this mean in terms of public health nursing practice? So there were some themes that have occurred from the oral stories that we looked at. So there were 8 public health nurses recently or newly retired, some of them that we were interviewed. And as I said, Gilda and Susan Walters did the interviews, the audio tapes. Some of the themes that came was shift to population health. So that changed from being a generalist district nurse to population health focus, that there was a decline in community development work, community capacity, community mobilization change. There was a real shift in that. That the program, immunization program, expanded. The world became a smaller place. There were a lot more outbreaks. There were a lot more vaccines being created. And so the immunization program began to really expand. Prenatal, foundation of public health nursing, shifted, and it became more moving out to the community and to the private sector. And now with doulas and midwiferys, that it's very much beginning to be more and more there. And then I had with several of the nurses that we interviewed had worked in rural nursing, and so I'll talk about learning to survive while you're working in the rural area. So the first one, generalist to population health focus. A lot of the public health nurses really spoke strongly about this shift, that it shifted from geographical district to focused nursing, but that they felt there was a decrease in continuity of care with the change. And that led then to sort of some decline in job satisfaction. So I'm just going to read a little bit here. So basically, one of the participants spoke about was in terms of looking at another change you noticed in her career was a change in funding. Near the end of her career, few nurses were expected to do more work, and they were neither as effective nor as satisfied with their work as they had been before. There were also big changes in employer and the healthcare organization, beginning with the Vancouver Health Board, which became the Vancouver Richmond Health Board, and then Vancouver Coastal Health Authority. Each of these changes affected the nurses and their work. So what we had done was we had created summaries from these oral audios, and so I'm going to be reading bits and pieces as I go along from these summaries. Here's another one that talked about in 1990 the health units were rearranged and Mid-Main Health Unit merged with West Health Unit to become West Main Unit. At the same time, there was a change in the way public health nursing was delivered, and the nurses no longer had a district focus, caring for all ages and needs. Instead, they used a focused approach in which each nurse focused on a particular age group within a wider geographic area. In this role, she was doing new baby visits only. She did not find this as satisfying as the district nursing approach, so in 1990 she transferred to the communicable disease team at the West Main. So we began to see that long-time nurses were finding that this work was not meeting their needs in being that broader range in terms of the generalist role. They had babies, they had preschools, they had daycares, they were at the school, they had the prenatal, but with the changes from that, now you either were just in what we call now the Healthy Beginnings team, which is the 0 to 2-5, so babies being born and looking after and then being engaged with their caregivers from 0 to 2 years of age, or what we used to call the early childhood team, 2 years to 5 years of age children, or the school team. And so that's how then we got divided, was into these population-based teams and providing care that way. So here we have a picture of our colleague Pat here, who described a major change in public health in Vancouver in 1986 to focus nursing. That is, rather than the broad public health role the nurses previously had, each nurse focused on a certain age group. And Pat then ended her career working with the school team and working in the youth clinics, and went on to actually, in that population group, while she worked, created some amazing things. And one of the things she created in her career was a manual for teachers on how to teach family life or sex ed in the schools. And it became the foundation from which we carried on building. The other shift that I talked about, that a lot of nurses spoke about, was the shift from community capacity work to acute care type of model. So once we shifted into being part of the Vancouver Coastal Health Authority, there was that shift then in terms of how we were organized and the work. So then it was that we were now less being engaged in community capacity, going out and doing outreach and connecting with our community members, and therefore which meant that we were doing less health promotion work and being where the community was, but more now being into clinics and being clinically focused. So to give you an example, one of the nurses had talked about how when they had run the child wellness clinics, a lot of times they were out in the community, either in a community center or a basement room of a church. Everybody knew the nurse would be there on a Thursday morning in the community and could come over and chat with her if they had any questions or issues. But now that if you want to go and see the public health nurse, you have to go to the community health center. And whereas the reception desk, there's not a nurse going to be available, you have to ask at the reception, can you see a public health nurse? They'll want to know why. Do you have an appointment? Why do you need to see it? Who do you need to see? And so there's not going to be that same ability to quickly then connect with the public health nurse. And so that loss of connection with their communities and understanding what are some of the health issues. The other thing that here a couple of public health nurses talked about was then the changes in the leadership once we became part of Vancouver Coastal Health Authority, and so that we lost leaders who understood public health nursing, were part of that and had actually worked their way up the ladder and knew then what public health nurses' work was about. And once we came with the health authority, that shifted, and so we have now leaders with more of a medicalized maybe background, or sometimes coming from other professional backgrounds that are in these leaderships and organizing public health nurse. And so therefore that shift to a more different type of model. And this again then led for a lot of changes in terms of job satisfaction. So community development and engagement, and again, my colleague Carol Wally is here, who was one of our participants in this project. And a couple of things. So I mentioned about Bridge Clinic. Well, it was Bridge Clinic occurred because of Carol Wally's leadership. She was in a management role and had that vision to sort of say, yes, we need a Bridge Clinic for refugees, government-sponsored refugees, or any refugees, rather than them showing up at the acute sector very sick. Let's then catch them early and really provide the services. And so it was considered at the time a really new idea, and in fact we have continued to be new, because from my understanding across Canada, we're one of the only ones established like that in terms of being able to meet the needs of our people who come to this country seeking refugee. So Carol was actually headhunted, what you would call these days headhunted, from Alberta because of her community development background, and her had done a lot of work over then in Alberta working with the public health nurses around community capacity working. So she came to us, and so Carol found her work challenging and exciting, especially when she was supporting her vision of community capacity building, which she saw as the foundation of public health nursing. And I think if you do speak to most public health nurses, they will say that that was our foundation, but that has really shifted as we have now moved more into clinical settings and not being as out there in the community. So just from her story, I'll share a little bit more. The city was planning changes in the public health program, moving towards a community development perspective. She was wanted for expertise in building capacity, partnering with community organizations, and engaging the community. This was a challenging change for many nurses who were used to more traditional ideas of public health nursing, such as home visits to new moms and hands-on child and youth programs. And so basically over that time, while we were very involved in community capacity building, we actually then had some amazing work happen that has been since then lost. We used to have a parent infant program for new dads, and that was back in the 80s, and then it went, and we've never had another program again as things have shifted. Or we used to have advisory committees from the public that would come and advise, be part of our programs to advise us as to what then would work for them in the community. And so Pat March had a lot of advisory committees, and she's here too this morning, and had several youth advisory committees and advisory committees in the school, and so did a lot of community engagement work in terms of trying to create healthy schools. So this is going back to the 90s, and if those of you who maybe are still active in public health, you'll know that we've come full circle, and the new program is called BC Comprehensive Health Schools, or Healthy Schools again, right? So we were there, then we were kind of pulled out, and now we're being told to go back and learn how to work with your schools and create healthy schools. So some of the things that have changed is also just because of what's happening in the world. And so the shift in immunization program changed and had a big influence on the public health nurses' practice. With the vaccine programs expanding, therefore more time being spent with the schools, working with them, this really changed our practice. So just to give you an example, in the 1970s there were 6 vaccines that children received. By the 2000, there were 16 vaccines. She knows that vaccine compliance was better in the 1970s, that means the parents following up and carrying with the schedule, than in the 1990s and the 2000s. In the early years, public health nurses would do follow-up after outbreaks, but later there was a special teams to do that. The real shift from a front line, knowing your community, being in the community, and being able to follow up with the outbreaks, now being to a centralized place that another team goes and does the follow-up in terms of outbreaks. And therefore, with the vaccine increase, that didn't mean we got more staff or more budgets. It just meant that we got loaded with more work. And so that really, if you talk to school nurses, we'll talk about how that has shifted their work in the school program. And as I talked about the healthy schools, that had a major impact. So one of the nurses that we did interview talked a lot about in terms of where she went. So I'll talk about other changes occurred in the high schools. In the 1970s, the public health nurses partnered with teachers for teaching family life education. Later, there was a system-wide change to focus blended approaches. Nurses were responsible for more schools and more immunizations, so there was less opportunity for collaboration with the schools and less time to get to know the staff and students. So as you can see, that really changed the relationships and partnerships. So that really impacted how nurses were seen as part of the school. We were considered one time part of the school, but then that changed that. We were not as visible in the schools, and therefore people sometimes are surprised when you say that all schools have a public health nurse attached to it or is part of that team, because they're not aware of that. The other piece, as I said, public health nursing was very much part of our foundational work. But again, it shifted over the last several decades. So in 1972, public health nurses were responsible for prenatal teaching, but later prenatal classes were shifted to a mix of hospital-based and community-run classes. And now, as I said, more to a private company. So as you can see from these old stories, that the prenatal classes began to change and have therefore changed the understanding of your client, because we would see them prenatally. We knew who was going to be having a baby, helping them along as their primary nurse. They had their baby. It would be the same nurse then we would be going on, carrying on, visiting. But now that we don't do prenatal, we don't see them, we don't know who might be having health issues or who might be needing more support and emotional support. And so they deliver the babies, and that's when we find out who the mom is or who the family is that has had a newborn. And we get a notice sent from the hospital to a public health nurses that this is the family that has a baby and it lives in your district. So it became a really sort of separated process. So it's amazing, though, also what some of the things nurses created when they were involved. So here we have a nurse who worked a lot, and she had worked in rural area too, but went on to design a curriculum for vaginal birth after cesarean birth. And then Jennifer Wonica, who was a big prenatal educator, she started a prenatal exercise class for moms, which at that time was considered very innovative and new. So again, sometimes we take these things for granted, thinking that they're always been there, but they haven't. They occurred along the way by public health nurses thinking outside the box and coming up with some new ideas. So as we go on, you'll see that the nurses actually had a lot of role in research, leadership, and coming up with some innovative program ideas. And so here Jennifer was quite involved in a prenatal research project with St. Paul's Hospital, looking at what can we do about low birth babies, and what can we do to make sure that these babies are healthy when they're born. Working in the rural settings. So one of the things that public health nurses that we interviewed talked about working in the rural settings and what that meant for them in terms of learning to survive out there. So when you were working in the rural area, you might be traveling by ferry, you might be traveling by car or a rail car, or even by a float. So this Susan worked in Port Hardy for quite a while and talked about all the different transportation she had to use in order to get to her clients and to her populations. So again, we're traveling along those logging communities. You had to learn how to be, in terms of your car broke down, how to survive and manage yourself, especially in the winter months, because then it could be challenging. So another nurse talked about how her mentor taught her how to check. So in her orientation, she got mentored how to check the radiator and battery, how to jumpstart her car, and how to put chains on the tires. They did not need to carry their vaccines in ice boxes because of the cold, so they just carried them in Ziploc bags. Okay, so I'm sure if people from Communicable Disease Department heard that, they'd be horrified, because we have now major training of how to pack a cooler with vaccines, how many ice packs, what must they be wrapped in, how much bubble wrap you need for this size container or this size container, and there's little videos made to teach nurses how to pack ice coolers to take their vaccines out. And then here we have nurses back in those days going in and taking vaccines in Ziploc bags. So I thought it was very cute. So again, talking about working in rural settings, this is Bob Sellwood, who finished her career off in a really high point. But one of the things that from her story I found was fascinating was that she was a 21-year-old who went off up north to work on her own and was really in an isolated place. And so sometimes when she would go out to visit her clients, her populations, or communities, she would be gone sometimes for 4 days in a stretch, right? So would go for 4 days, come back, and then be gone again for 4 days. And while she did that, over the 4 days, she had to lug everything with her in regards to her clients' forms and files and all that confidentiality information that we sort of, worry about. But she had to take it all with her, on whether she went by plane or by ferries, had to lug it with her and be away from her family while she was working in Port Hardy. And so one of the other things I want to sort of say is that in the urban area, yes, public health nurses moved to a focused nursing, but in the rural areas, it's still more of a generalist role, just because of the necessity of how that's set out. The nurses then are still doing more of that broader range of public health nursing skills. So in terms of just talking, and one of the things I want to stress is how much public health nurses did in terms of their work, but also sometimes the leadership roles they moved into, or sometimes the things that they developed, so the manuals, the programs. And so in terms of for Bob, before she became Vancouver before she became a perinatal coordinator, so she went on to become a coordinator for the perinatal program for the Vancouver Health Board. In that role, she revamped, reorganized, and centralized the perinatal program in the city. In partnership with BC Women's Hospital, she developed a prenatal curriculum so that there would be standardized, evidence-based resources across all health units. She also consulted on a provincial resource, Baby's Best Chance. So those of you who maybe have had grandparents or grandchildren know where the Baby's Best Chance comes. Bob Sellwood was kind of one of the driving forces for that booklet and making sure that we had current standard evidence-based information. Ms. Sellwood's other roles included Manager of Prevention for Fraser Health, Board Member of the Canadian Prenatal Nutrition Program, and Member of the Provincial Community developing guidelines and nursing pathways on breastfeeding. And so some of the pathways that are currently, that we use now in community in terms of public health around the maternal newborn were first established by Bob, who was very much into evidence-based practice and making sure that we were all had standardized practice and bringing us all onto the same page. So again, in terms of looking at where have the nurses been doing, is that's really leadership innovative program has happened. So one of the couple of things that kept coming from the interviews was that they had all at some point been in a leadership role just because of that was the way it was, that there was, you moved in to take a lead, whether you actually were paid into leadership salary wasn't always the case, but you took on an initiative to create a manual if it wasn't in existence. You collaborated with other organizations and pulled together. And so developed programs such as Bridge Clinic, Healthiest Babies Possible, Safe Baby. They didn't exist in the 80s. Those were much later, late 80s, early 90s that they came to be established. And then again, as I said, developing some of the resources and the manuals. And then some people have sat on boards to establish youth centers. So we didn't always have those youth centers that we sort of take for granted. The Broadway Youth, again, Pat March was very instrumental in trying to get the Broadway Youth Center established. And I think for 18 years, Pat had sat on the McCreary board. So for those of you who might know McCreary, it's the Adolescent Health Survey that's done here in BC, and she's been on the board, even in her retirement years, still giving to the community. And as I said, the prenatal programs, they were also came out of public health nurses really beginning to look at what were the needs. And then, of course, they were always sitting on advisory committees. And sometimes you sat there as a volunteer because public health nurses were graded in terms of the leadership and weren't always representing maybe your organization. Okay, so I'm going to finish it off there, maybe up sort of looking at what are next steps. So this was a pilot project, and as I said, we had 8 recently retired public health nurses looking at their work over the past 5 decades, and what I've pulled is just short, small snippets from each of their stories to kind of give you a sense of what some of the changes in practice were, going from that generalist district nursing, knowing your community really well and being engaged, to now sort of focused nursing, but focused on more of a population concept, and therefore not maybe also always being as out in the community in terms of health promotion outreach, and being moved more into the clinical settings and doing services and provide that way. And still trying to, those of us who are passionate, still try to do some community development work in terms of getting out to the community and building partnerships. So we'll see where this takes us, but it has also established some very clear processes that can be used in terms of collecting digital information, guidelines around in terms of archiving and storing it here at the UBC, and then depositing them, and then who has good access to them, and being able to have them that the public can access that information. Okay, so thank you for listening. Questions?
So much. Who can I answer?
Thank you. It was fascinating, and I loved it. And there's so many implications from this little piece of research for education, for policy making, and the theme of the dissatisfaction of the nurse that keeps coming up, and how is the employer at the very highest level having to deal with this, and where they're going to get the next nurses. It is a lovely, interesting, fascinating piece of how history of nursing research and oral history research can be applied. So I'm really excited. And are you going to continue this? Are you looking for more interviews? Are you going to be able to do more interviews? Talk.
I think we're finished. We did have Erica Roberts to help us guide, but we are hoping, I know that some of us are still keen because we know we didn't get to some of the people that we wanted to. There were some people who were on vacation. There were some people, said not now. So there were some other people that we had really wanted to interview, but we'll see. We're not sure yet. And so I think it's sort of just finished and we kind of still need to come back and look at that. Yeah. I think that's where we're at. Yeah, we'll see.
Okay, then Sally and then Suzanne.
Oh, that was fabulous, Ranjit. And one of the things that struck me the whole time you were talking, I think just like Linus, that it's the structural things that seem to be dominant in everybody's thinking. And it occurred to me that in the public domain, you would assume that the biggest barrier would be these changing complexities in populations. And it just seems to me that your nurses just rode through that absolutely. I mean, that's what we do.
Yes.
And that wasn't the dynamic. People know how to deal with that. It was the structural things that allowed them to do what they were doing.
Yes, and I think that was what I would say the best years or the golden years were when we had that kind of leadership that understood public health nurses. And so if you said, I want to run this, it was like, go, and what can I do to support you? Now you have to, submit proposals, you have to fight for it, you have to advocate for it, you have to ask for your time. Yeah, very measurable to say why. And so it's a real challenge because sometimes it's hard to do that and then that work and it gets dropped.
Great job, Ranjit. Thank you so much. What would be your message to our younger nurses? We know that the province talks about moving more back into public health, community health, nursing. How can we be mentoring, role modeling, and making our new nurses passionate about this and preparing them?
I think it would be that we really need to install that passion because I think sometimes they're fearful about will I be able to get work there, but as you said, that province has been talking and the health authorities keep talking. So if you go to the mission statements, they talk about community, home is best is the new logo, right? And if you haven't seen lately on Vancouver Coastal Health site, community engagement is also there, but yet it's not always the way we're seeing the action happen. And I think it is really important that we as public health nurses or even as nurses be really advocating for then that shift to happen to the community where we know where most of our population is, and that it can help to decrease the burden on the healthcare in terms of the acute sector if we're able to keep that population healthy. And so I think one of the things I try and tell my students is that don't take it for granted that this program was created by the ministry or by Vancouver Coastal, said, hey, we've got this population problem, we're going to create this program. That's not how any of these programs came to be. They came to be because the nurses were out there in the community, engaged, saw a problem and said, we need to do something about this problem. What can we do? And began to then work at addressing that. So whether then the Safe Baby Program, for those of you who don't know, is a program for women who have addiction issues and have a baby. And so we work with the foster homes or with the mom and the baby if the baby comes to them. That didn't just happen. It was with nurses advocating and saying we need to help these moms that and establish Bridge Clinic, the Healthiest Babies Possible program. They were all from the side tables that of nurses that began to do the parent-infant groups. They were not always there that we run now. They were because nurses said, hey, this would be better. And so really beginning to get the students to think outside the box and think big and think holistic. And I don't know if any of my colleagues that are here who have been great in the community wanted to address that and what can we say to the students, the future nurses?
Can I say something? I think that the permission to start projects don't have to come from the top. They have to come from your more immediate supervisor. And I think that that's a significant thing is for that relationship. They don't have to come up there. Up there, they don't need to know.
That's how we sometimes do it. No, they don't need to know.
They're dealing with, to be honest. So I think the permission is, and if it works, it works, and then you can take it forward. If it doesn't work, well, that wasn't the end of the world. So I think that's where the permission is, and I don't know how you do that. And I got permission from Carol to do those things. So that's why I can say that.
And I think that again points to that understanding of public health community work, right? So Carol came with this really clear understanding of community development work, community engagement. And so many of us got lots of permission easily to do this, do that. And so I think that's the concern, is that some of that leadership has changed and some of the leadership doesn't understand that community capacity, community mobilization, community development, engagement work, what that looks like and what that means and what you need to have in order to do that, in order to be able to then carry this work out effectively. I think I saw Wendy and then Carol.
And Joanne as well. Because, Carol, Joanne, and
Start me to go first? Sure. Okay, I was just thinking about some of the projects and the history and stuff that I think from my experience, having a connection with the community at every level. So if you're going to start something new, that there's somebody from the community that's part of that project or advisory to or something, just connecting, I think that builds a really strong foundation for you to take risks and that sort of thing. And at least that happened for me in my experience. And the other question I have is, I don't know much about home care now, but I mean, I do, but to me, there was always an opportunity for bridging between public health and home care because it's all community nursing. And I feel that wasn't necessarily, but I think there's, in rural areas, when I started a home care program in Alberta, you had no choice. Yes. You had to build with whoever was there. The building blocks were the people that were there. And I think that that's something I've kind of noticed, in that's not, they're not real connected, where maybe there's opportunities for more of that.
I think it was
Thank you, Randy. I think this project has really identified some gaps that have done full circle now that we're seeing in public health, as you and I know, teaching the public health course. And I don't know, and I think how you've identified and had the individuals interviewed brings it together. So maybe even more interviews will beef it up a little bit, but take it forward to, you know, higher levels, because I think when we see some of the issues in public health today and some of the erosion of public health nursing practice and the scope of practice being taken away from public health nurses, I think this could help bring it back into public health nursing practice. For example, we have, you know, public health nurses don't teach prenatal classes anymore. And we have hardly any prenatal classes available, and those that are available are $350 to $400. How many people does that marginalize? Tons. And they're centralized only at St. Paul's. BC Women's doesn't even have them, or you have this private one. So I think there's lots of areas, and then we look at the scope of practice of pharmacists wanting to do infant immunizations. And that's not just the fact of giving the immunization, it's all the rest of the public health nurses doing the developmental assessment of the child and connecting with the mother and doing the postpartum screening and all those kinds of things. So I think what you found with the nurses who've given you their historical perspectives, I think even though they're talking about community as home, I personally think some of that is still lip service, and they're not actually putting their money where their mouth is. And I think the voice of public health nursing, past and present, has to step up and get on the bandwagon and stop the erosion of true public health nursing, which is what your nurses did.
great. Thank you.
Well said.
Well said. Wendy, I think.
So that was absolutely fascinating, and thanks, Ranjit. I really enjoyed it. I just wish I'd heard this before I was in Fort Nelson, because I was just in Fort Nelson for a couple of days, and I happened to be talking to a public health nurse up there, and she was actually saying to me that she was really upset about doing generalist public health nursing because she felt like she couldn't stay on top of all the different areas she needed to be practicing in, and she wanted a more population-focused approach. And if I'd been to this first, I would have known how to respond to her, but I didn't really know what to say. So what would you say?
Well, I think I don't know, it's tough because when we were in the generalist role, and I think several nurses also identified that you actually had that continuity of care. You saw them prenatally, you saw the child in the clinics, immunizing, child wellness, you saw them if they were going to your preschool or daycare, because you tended to have that district, geographical district, and then you were the nurse for the school, so you knew what kind of background they came from, so it's easier to actually put prevention into place, and now it isn't because it's very population focused, so you don't know what the background is or where they came from or what the history is for them. And so I think there's that, but whether then it can be expanded more, I'm not sure, but for me, I think the generalist role did meet that. On the other hand, when we were population focused, sometimes then allowed you as a practitioner, which is what I think she's saying, is to really hone in your skills and knowledge into that one population and have a clear understanding of what could be done then to meet just that population. I don't know if the managers or leaders are guilty.
And I think that's true. The population allowed you to focus in, but sometimes you couldn't move. You know, so you couldn't go anywhere else. It was something became more and more difficult. It didn't used to be, but then it became more and more difficult. If you were a school nurse, then lo and behold, you couldn't do babies unless you had extra
did some
whatever.
training or
So
something.
that really is so on public health. And so I think that's what started to happen. And I don't know if it was meant to happen, but that's how it, with the population health, so focused that it limited from, I think, more of a higher level, the moving back and forth between those. But it definitely, population health definitely gave you, for instance, Healthy Beginnings program. When we were in the district, we saw babies maybe at 2 weeks, our first visit. Healthy Beginnings came and we were going in within 24 hours. So your skill level is different. You're seeing a lot more acuity and so on. So, you had to learn a whole more acute sort of skills. So that was good in that sense, but then somehow you lost that whole perspective, after they're 2, then, and some people got really, just doing babies all the time wasn't satisfying enough, if that's all you were doing. You didn't get to see the school-age kids and the older seniors and that kind of thing, so, I don't know.
I think Sally had her
Last comment.
Sally?
I was just going to appreciate the observation that you made, that nobody's fault and probably nobody intended it, but it really strikes me how important it's going to be to make sure that the next generation of nurses really does understand those administrative structures, policy decision-making structures, political processes, the program management that caused people to be interchangeable and eroded those lines of reasoning for nursing, to know who their nursing leaders were and having leaders at the right places. Those are all concurrent with all of this, and I don't think they're coincidental. So it just really brings home how terribly important it is to excite all nurses. And you know how baby nurses don't really think administration speaks to them. They think that's somebody else. Well, it's got to be our job to make it really exciting and important to them, because this is the kind of thing that we all need to be able to grapple with.
And I would say what Carol mentioned too, in terms of the generalist skill to build community. Yes. That what we now perceive as a loss is in some ways a change. And all changes always come with a sense of loss. People resist change. But if you, under that, see how the nurses have a skill to build community, then that can be carried over, whether you have a specialized field. And I think we had this discussion even within our team of doing this project. There is an element of team building that you need to make a project successful, whether it's a public health project or whether it's an oral history project. And I think you have illustrated that fantastically, Ranjit, today, that the true richness of public health is also that skill to build community. So I think that is a real take-home message that you've given us. So thank you very much. And then feel free to stay around, but we give you a big applause because some people have to leave. And thank you so much for an excellent insight in public health nursing today.
Thank you.